Hello, everyone. My name is Aiste and I'm delighted to welcome you today to this special, a little bit different UCARE webinar. Today, it's all about the most common questions that the patient asks us about urticaria every single day. Now, today, as already mentioned, this session is going to be a little bit different. There are no presentations, no slides today, just a real talk. Because let's face it, we've been observing for quite a while, and we have very well noticed that living with urticaria can be confusing, frustrating, and very much emotionally draining. As the doctors and researchers who work with this condition every day, we see it, we hear it, and we care, and we want to address it. We know what and how appointments sometimes are way too short, or your worries just simply go unnoticed. We see all the misconceptions being shared on social media and patient platforms, and we understand that sometimes the most important questions go unasked or unanswered. So that's why today the world's leading experts in urticaria are, well, simply inviting you to pull up a chair and grab a cup of coffee with us. Join us for a friendly and honest conversation where we talk about all you want to talk about, the things that matter to you as the patient the most. And UCARE is an incredible platform that brings together the leading experts in urticaria from all corners all around the world. And that's exactly what makes today's conversation so special. We are able to share experience from all around the world. And it's my pleasure to introduce our panelists joining us today. First of all, from Spain, Professor Ana Maria Giménez-Arnau, welcome on board. Welcome to the webinar. From Mexico, we have Dr. Désirée Larenas-Linnemann joining us. Hello and welcome. And also, straight from Qatar, Dr. Tayseer, Sabah, Alsaeed, Mohmmed, Ibrahim, welcome, joining us from this corner of the world. And finally, from Canada, Professor Hermenio Lima. These all amazing experts are gonna be talking all about things that matter to you. And trust me, we have done our homework. Over the past few weeks, we have collected your questions through social media, during our consultations, and in patient support groups. We've been listening closely what you feel that is still missing when the conversation turns around urticaria. And today we're putting it all on the table. That said, the question list is still not set in stone, and you are entitled to ask all the questions you still feel like. However, you are joining from 44 countries all around the world. So please feel free and use this option, use this chance, because I'm pretty sure that you see somewhere on your screen the tiny little question button, chat button, and don't hesitate to set your questions in there. Question box is always available and we will be sure to address all of your questions. But without further ado, we are not waiting any longer, and we are starting with our initial question set. So first of all, dear Hermenio, welcome on board. And you are allowed to introduce us a little bit better to urticaria. And it's very good to have you here. And if you don't mind, I would like to ask you then, so what is this urticaria and how can we know that a patient actually has it? How would we describe it and how do we recognize it?
Thank you very much. It's a pleasure to be here, and it's an honor and to be with this group of panelists from all over the world. And what urticaria and how we have it. Urticaria are lesions that dermatologists call hives, or it can call wheals, that comes spontaneously, or sometimes it can be induced for specific kind of situations. But basically, they last for a certain period of time, usually less than 24 hours, and it can occur in different parts of the body, and it tends to be very, very itchy. So that's how we know that the patient have. And from that point, we have different classifications. So this is one of the most common diseases that the patient itself can make the diagnosis. It's already come to the doctor with the diagnosis.
Great. And you have mentioned the right thing. The patients do like to self-diagnose before even coming to the doctor's office. But Anna, if you don't mind working every day in the clinic, and when you first see the patient that comes with a suspicion of urticaria, how do you differentiate the disease from any other skin diseases? How can one know that the patient is experiencing maybe allergic reaction, or is it urticaria? Maybe it's a side effect of medication. What is the process that the physician goes through to actually find out that this is a real urticaria?
As Hermenio mentioned, it is an inflammatory cutaneous disease which the elemental lesion is a hive for the wheal with sometimes angioedema, but commonly is very itching. Then commonly the diagnosis being clinical, and the patient always think that probably they suffer from an allergy, which is not true. But the lesions are evanescent, fleeting in nature. They disappear from one part of the body and appear in another part of the body, and they change their location along the day and one day from the other. And suddenly the patients tend to see that probably is important if the lesions appear on the hands or on the head, and they tend to think that probably they are extension, they change, there is an extension, but the real thing is that we should identify the fleeting nature of the wheals, the hives, how they disappear, and all of them, they think that this is a sort of allergy, and they try to remove triggers that they think probably will be the cause, and we know that it's not a pure allergic disease, except for certain types of acute urticaria where really a real allergic disease is demonstrated. But the word allergic is so strong. And then even if we explain to them that urticaria is not really chronic spontaneous urticaria inducible, is not really an allergic disease, is autoimmune or it's induced by things which are not related with environmental factors strictly, they return to the consultation and they repeat they should be some allergic to something. For example, allergic to cold or to the sun, although it's urticaria. Then we cannot eliminate the word allergic when it still is not an allergic reaction. It's too strong.
Yes. Thank you so much. I think for the patients, it takes a little while to wrap their heads around it and to actually understand what does it mean, how does it work, and to actually quit looking for triggers. And it's especially difficult and especially complicated when the patients are experiencing angioedema. So, dear Tayseer, it's first of all very good to have you on board today. And could you please elaborate a little bit more on angioedema, how it is related with urticaria? Is it dangerous? What should we take a look into that? And what are the differences between angioedema and urticaria?
So angioedema is a deep swelling of the skin. It can be erythematous or red, or it have the same color of the skin. It can affect the eyes, the face, the lips, hands, and feet. It can be part of the urticaria, where we have the patient have the hives, itching, and the angioedema together. Or the patient can have only the swellings or the angioedema, and the angioedema here, it happens due to the same mechanism why the urticaria is happening, because of release of histamine from some of our immune cells. And angioedema, it can be alone also in another condition that is not related to urticaria, like hereditary angioedema. How we differentiate between urticaria and angioedema? In angioedema, we don't have the intense itching like that we'll have with the wheals and the urticaria. And angioedema, it takes time to resolve, maybe up to 3 days, rather than the hives which appear and disappear on the same day in multiple sites of the body on the same time. Having urticaria angioedema, it is not dangerous. It can be dangerous in other conditions where it is due to allergy, if it affects your throat, and at that time the patient cannot breathe properly. But as part of urticaria angioedema, it is not dangerous.
Thank you so much. So, Désirée, could you just make a clarification point? So, about it being urticaria or angioedema being dangerous. Sometimes patients come in and they want to have an emergency set. Do they need it? What should they do? Do they really need it? And if they have angioedema, what they should be acting on? What should they be observing on to see if they actually need some help with urticaria and angioedema?
Yeah, I think the concept is very important, and it's not only the patient who comes in with the question, but it's even, well, here in Mexico where I live and work, the physicians who say, oh, be careful because it can go inside, no? Es le puede ir para adentro, which is completely not true. Well, what is the confusion here? We're speaking here about a disease that is called urticaria, and urticaria can have two manifestations. Urticaria can have the wheals that we were speaking about, they're there, then they're another part of the body, and urticaria can have the angioedema. Now, those two manifestations are from the same disease that is called urticaria. But there's another disease which is called anaphylaxis, and anaphylaxis can have as one of the manifestations the same swelling or the hives. But then together with that comes that your bronchi can close, you get bronchoconstriction, or you can get a lowering of your blood pressure, or you can get symptoms in other organs. This is anaphylaxis. This is not what we're talking about. We're talking about urticaria. So those are two different conditions, although both can have the manifestation of swelling of the lips, swelling of the eyes, even swelling of the how you said, intimate parts and the hives together with it. So if you only have symptoms in your skin, and this has been going on for several days, then we're speaking about urticaria. We're not speaking anaphylaxis. So that's where we should not make the confusion. No, but if the patient comes in just with half an hour of all of a sudden onset of symptoms of hives and swelling, yeah, then we should be a bit more careful, because then it can be part of what is an anaphylaxis. But normally anaphylaxis, it develops within minutes, max 15, 20 minutes after being exposed to something that gives you an allergy. And here is really a very severe allergic reaction. So I hope I've been clear here. Then there's one more condition that doesn't give hives, that only gives the swelling, which is the angioedema. Well, the angioedema is like with a different mechanism, and if the patient takes antihistamines, they don't improve at all, because here the mechanism of the angioedema is completely different in another set of molecules. So you can differentiate the only angioedema, which can be hereditary, which is very rare, or which can be acquainted in some conditions of the patient as well. Then you can make the differentiation that if they give antihistamines and it doesn't go away, then we're speaking about another kind of angioedema, which is not part of the famous urticaria that we're speaking about today. So I hope I made myself clear here.
Exactly. Thank you so much. And I would like to use the chance and put a question from the audience right away, because we have quite a few patient organizations joining in. And it's amazing that we have such an intercultural experience today. Maybe you can all contribute to this question a little bit, because when it comes to angioedema, we have quite a lot of fears surrounding it. And sometimes the first contact person that a patient goes to is actually a patient organization, and the patients always ask, and they always have extremely high level of fear that they will suffocate due to angioedema, especially if it happens somewhere around the neck, around the respiratory tract. So how can this constant fear and how this can be alleviated? What would be your advice, and what would be your message to the patient in this case?
Yeah, well, if it's only angioedema, and again, this is a very, very rare condition, hereditary angioedema or acquainted area angioedema, then I think there's no other way than going to the emergency room. But if it's only angioedema and you don't have any wheals and it's really of sudden onset, because then we can differentiate, and sudden, again, here I'm speaking about half an hour, max maybe 1 or 2 hours, no more. Because if it's already longer, then it's an urticaria, and it will never go inside. I don't know if any of the colleagues would like to add anything more, because then, yes, then taking antihistamines and everything, it won't get you better. So also, if you have your angioedema, you take double antihistamine and it's just the same, then you better go to ER, I would say.
Thank you so much. I hope this will be a take-home message to the patient organizations also and to the patients. And now, Hermenio, please let us know a little bit about the predispositions or a little bit more on statistics. So what people and age groups, populations maybe, have the higher prevalence of developing urticaria? Because sometimes the first thing people Google, am I able to even develop that? So what would be in this case?
Thank you for the question. That's a very interesting question. Like as Anna mentioned, Dr. Giménez mentioned at the beginning, this is an autoinflammatory disease. So the first thing that we have to imagine is that there is a certain maturity of the immune system. So the prevalence, urticaria is not a very common disease, is not a day-by-day kind of in the dermatology kind of office or allergist kind of office, but it appears. And we have any age that can develop this disease, but usually we expect a certain level of maturity of the immune system, that the immune system go dysregulated and start to develop the disease. But the majority of the patients tend to be adult patients. That's when they have the disease. But it can occur in any group, and there is no specific population. Any population can develop this disease. There is no preferential kind of group of patients or race, color of the skin, or anything that we know.
Thank you so much. So the immune system has been mentioned quite a few times. So Désirée, could you please put the cherries on top and put the dots to an i's, whether the urticaria is actually autoimmune disease, because the patients sometimes come in and they say, oh, my immune system is completely all over the place. It's completely chaotic. Is this actually overreaction of immune system? And is this actually an autoimmune disease?
Yeah, this is a very good question.
Okay.
It's a very good and complicated question, because well, lately, and this is really, we've been learning about this in many diseases, that there's different mechanisms that are below what we see. Now, again, we see the urticaria. Now I don't go up to the different causes of the wheals. Now I go down to what's below the skin, what's happening there in the skin, which finally makes the wheal or the swelling. Well, this can be primarily two different pathways. One of the pathways is where my own immune system attacks the cells that finally will put a histamine in the environment and then make the wheal. This is kind of autoimmune because here my own antibodies attack those mast cells, and the mast cells then will liberate the histamine, and that gives the wheals and the swelling. Fortunately, this is practically only directed to my mast cells. So it is related with a little bit higher frequency of also the other horrible autoimmune diseases, but this is normally not the case. It normally only goes to my mast cells, and that's it. But that's also why we see it mostly in women. They're much more frequent with chronic urticaria than in men, and mostly in the 30-40 age range, which is like the peak. It can be any age, as we just spoke about, as Hermenio told us, but it peaks like that age range. Then we have the other possible underlying mechanism, which is with IgE, with immunoglobulin E, which is also the immunoglobulin of allergy. And that's where the confusion and the mixing with allergy, the allergy thoughts come in. Now, when it's like IgE mediated, that is why omalizumab, which is, we will speak about it in a while, but it's a molecule against the IgE, is so good for this kind of urticaria, which we also sometimes can call even autoallergic. But again, here the IgE is not to an allergen, so it's not the real allergic disease. It's to my own substances of my body. So in this case, really the patients are normally much better responding to antihistamines, to omalizumab, etc. When it's more like the autoimmune, my autoantibody against my mast cells, then they need some higher doses, or sometimes it's a little bit longer it takes before they really respond well to therapy. But finally, the characteristic of the lesion is just the same. So only your specialist will be able to differentiate both both different endotypes, as we call them, underlying mechanisms.
Perfect. Thank you so much. And we are finished with the first round of first question set. I'm super happy to see quite a few questions coming in the chat. We will be addressing them slowly, one by one, and we are answering them also in the chat. So,
Aiste,
yes.
may I do a comment?
Yes, of course.
May I do a comment? I would like to do a comment to Hermenio, because he already explained that really the urticaria can be suffered by all the ages, and it's true. And it's true because initially in our series, although the peak is in adult patients, more than 25 of our patients started with the first episode of chronic spontaneous urticaria after 65 years old. Then take care on this. And also when the children, they suffer from acute or chronic urticaria, they have some spatial behavior. Sometimes the infections are much more common, the trigger factors. Then all the years they can suffer urticaria, but there are some little differences between ages, and also there are some little difference between patients that suffer urticaria, because most of them, they will suffer just, when they suffer chronic, they will suffer just one chronic episode of chronic urticaria that maybe long last 3 years or 5 years with daily hives, which is one thing. Mm-hmm. But there is around 20% of the people that will suffer along their life more than one episode of chronic spontaneous urticaria. And that probably this is a subgroup of patients which are prone to develop urticaria more than the others. And when Désirée explained the endotypes, you had a question from me before that if there is a cluster of other autoimmune diseases in the patients that suffer autoimmune urticaria, how she explained. And it's true, there is 20% of the patients with chronic spontaneous urticaria, with such probably that have this true IgG against the high affinity IgG receptor and respond lower to omalizumab, that they have another autoimmune diseases as hypothyroidism or other autoimmune diseases, chronic colitis ulcerosa, diabetes, etc., because there is a cluster of autoimmune diseases in a part of the people that suffer urticaria. Then regarding of the patients, they are not exactly all of them the same. This is why they need to go to the specialist, because we should recognize the type of the patient who suffers such acute or intermittent or chronic urticaria according with the conversation that we have with them. Not all the patients are exactly the same. This is
of course. The individual approach is very, very much important in the treatment of urticaria, especially as the personalized therapy options. And each patient has probably a different time point or the different time point exactly when the urticaria appears. So Tayseer, could you please elaborate a little bit more if the reason actually that has been an initial trigger, if it can be followed back, what it can be, what could have been a main trigger to development of the disease? You're on mute. I'm sorry. Yes, now.
So, sorry. So Désirée already told us about what is behind the skin that causes our symptoms. That the mast cell was activated by either autoantibodies or by the IgE, and that is why the patient has symptoms. So it is chronic spontaneous urticaria. Spontaneous means that it happens without any other cause. This is what we are always trying to convince our patient with. But there are some triggers that can trigger the symptoms, like food, for example, food additives, food coloring. This is something that can trigger the symptoms. Some medicines like aspirin and other medicines that used to relieve pain can also trigger the symptoms of urticaria. And other fish, for example, infections. These things can also trigger the urticaria. This is all about spontaneous urticaria. We are not touching inducible urticaria, which has other physical factors that might exacerbate it. So how the patient can know that he has specific triggers? By keeping a symptoms diary, because it will help the patient to track his symptoms. It will help to know when the symptoms start and when it's resolved. This is also when he came to the clinic visit. With this information, it will help the clinician also to guide him further. And he will be able to notice what exactly trigger his symptoms.
Thank you so much. So, Anna, you have mentioned the connection with autoimmune disorders and chronic spontaneous urticaria before, but then let's switch this question a little bit and tell us what you think. Should the patient undergo a multiple laboratory testing or clinical examinations if there is a suspicion that the patient may have association of chronic spontaneous urticaria with autoimmune diseases?
Yeah. Thank you very much for this question. It links a little bit with what Désirée explained before with the IgE levels. Initially, we don't need a lot of complementary tests to do a diagnosis of chronic urticaria. When we are linking urticaria with autoimmune disease, we are talking about chronic spontaneous urticaria, okay? And we are in such cluster of patients that suffer other autoimmune diseases with concomitantly chronic urticaria, but the treatment of chronic urticaria is one, and the treatment for the other autoimmune concomitant autoimmune diseases is another. That means if you have an hypothyroidism, you will not cure or control your urticaria with the treatment for the hypothyroidism. You should have the treatment for the urticaria and for the other autoimmune diseases. And such patients tend to have a baseline level of the total IgE less than 43. Your specialist can, with a history, try to ask to the patient, try to ask to you if you are concomitant other autoimmune diseases, when is one of the first questions. And commonly, these patients, they have lower levels of baseline total IgE compared to the other chronic spontaneous urticaria patients. And this helps, as Désirée mentioned, to predict certain response to certain type of treatment that we have available today, not to the anti-H1, but yes, for the efficacy of cyclosporine and the good efficacy, but maybe it's lower efficacy with omalizumab.
Thank you so much. So, Tayseer, could you please just shortly let us know if urticaria is somehow related to other allergic diseases, such as allergic rhinitis or asthma? Is there a connection now?
Yeah,
yes, actually.
Oh, sorry, me or to Tayseer?
Tayseer.
You go ahead, Désirée. Go ahead.
No, you go, Tayseer. As an allergist, I jump on this.
So, although we are, there is a connection between urticaria, allergic rhinitis, and asthma, as we said before that the IgE, the protein of allergy, it has some actions to do in urticaria. This also, it has a major role in patients with asthma and rhinitis. So we tend to see patients with urticaria have rhinitis or have asthma, or the vice versa.
Thank you so much.
But Tayseer, do you think that because we have patients here that probably they are atopic, we can define urticaria as an atopic disease?
No,
No.
Talking about the allergy, the pathophysiology of urticaria. So we have the autoantibodies and autoimmunity, which is not in the pathophysiology of asthma or rhinitis.
Yeah, okay. I would, as an allergist, sure, I have to add on here. There is a specific, it is not common. It's absolutely not common, but we have a very strong ash tree pollen season in winter. And I have some patients who only at that moment get their hives, and sure, I use a lot of allergy immunotherapy together with allergic rhinitis and sometimes asthma added or allergic rhinoconjunctivitis. And if they have this very clear seasonal peaking of their urticaria and I start allergy immunotherapy, it is very common that the hives go away after 1 year of good, solid allergy immunotherapy. So in these particular cases, I do think that the allergy part is not autoallergy, but allergen from outside. But it's really a very small subgroup.
Then you're mentioning urticaria induced by aeroallergens. It is in seasonal part, but this is not chronic spontaneous urticaria. Although we can have patients with chronic spontaneous urticaria that simultaneously they can be atopic around 18%, and also in cholinergic urticaria.
Because there's allergic rhinitis is in the general population in a fifth of the pets. It's just coincidental. Yes, I very much agree, Anna. Yeah.
Amazing. So then we move to another topic about the stings and insect bites. Hermenio, could you please elaborate on this? Because sometimes the patients also have a huge fear against any type of insects if they have urticaria because they are afraid that it may trigger this.
Yes, that's a very interesting question. Again, like what Anna mentioned and Désirée also mentioned, everyone here, Tayseer also mentioned, we have to individualize and identify. So a good history is very, very important. There are circumstances that we call urticaria. Among them, one condition is called urticaria papulosa, which is basically an allergy to the insect bite, which it can activate the history of insect bites that the patient have. But it doesn't mean that this is a chronic spontaneous urticaria or a chronic induced urticaria. You have allergy to the insect bite. There is more severe situations where the patients can have allergies to bees, and this is kind of can be a deadly disease, including if the patient do not have like a situation that it can trigger an anaphylactic reaction. But these are very, very specific allergies. Remember, we are dealing here with autoinflammatory diseases, and that's what we have to separate. However, going back to what Désirée said, if a patient have already history of urticaria, any other history of inflammation that can be triggered can amplify the inflammation. So like suppose the patient has hives and go to a situation like here in Canada, in the summer, they love to go to fishing, and they can get bites multiple times that can trigger a upgrade of the activity of the disease. But it doesn't mean that induced urticaria or chronic spontaneous urticaria.
Thank you so much. And Désirée, we have heard about multiple triggers and more aggravating factors. And we've talked about infections already, but what about medication? What medications should be avoided? What medications may aggravate or trigger or worsen the symptoms of chronic spontaneous urticaria?
Yeah, I think, again, we have to be very careful here. First, I'd like to separate out, and we've been speaking about both terminologies, but we have not defined them very well for the public, maybe, the chronic and acute. Now, because the very first division is this chronic or is this acute urticaria? When we speak about acute urticaria, this is less than 6 weeks. The hives come and go, the swelling comes and goes, but for less than 6 weeks. And then the causes are very different than when we speak about the chronic, which is oftentimes only the autoimmune or the autoallergic part. And there's no external trigger. Well, no external cause. There can be triggers, but not causes. Then if you speak about the acute one, there the first cause in children is actually an infection. Not only a viral infection, and then again we get mixed up because the infection causes the hives because it causes the activation of the immune system. But if simultaneously you gave some medication, then the people think it was the medication that gave the hives. But if they give the medication again in another infection 2 months later and there's no hives, then we know this was not the cause. No, that really the infection was the cause. So this is important for the children. Also in adults in acute urticaria, we always have to check if there's no sinusitis, if there's no tooth abscess, if there's no important also Helicobacter pylori, gastritis, or here in Mexico, parasite infections that could be the cause of the urticarias. Any chronic infection in your body, which just activates and activates and activates the immune system, is able to, again, trigger urticaria. About medication, well, here there's several medications that can cause again, we have to not confuse here urticaria and dermatitis due to medication, because that's oftentimes also confused. But then if it's a dermatitis caused by medication, then it's not hives. It's not a lesion that comes and goes. It's just the skin that is red and bad and a lot of itching, but it doesn't come and go, as is the case in urticaria. If we speak about several medications which we very well focus to be linked to urticaria, and maybe even here to chronic urticaria, because people take them sometimes prolongedly. This is, yeah, sure, the NSAIDs, aspirin and all its derivatives. Normally not so much paracetamol, acetaminophen, and also the very pure inhibitors of COX-2. This is maybe a bit too technical for patients, but this is very much more for physicians. Those normally don't give the problems. Now, the problems are much more linked to aspirin and its linked medications like naproxen, diclofenac, ketorolac, etc., etc. Then sometimes also certain anti-hypertension medication can be linked to chronic urticaria. And again, this is oftentimes more together with the swelling as manifestation of the urticaria. Important to go to your physician. I don't want to go too much in detail here for the patients, because I don't want them to stop medication. It's very important to them. So this is really two more important things. I love the proteins that people go to the gyms take, because they're super forgiving hives, and it gives me a lot of patience. So I love it. I think very important message. Don't take those proteins. It's crappy stuff.
That's a very, very important take-home message. That's for sure.
Desi, just one thing, Aiste, Hermenio, Tayseer, Desi. If you have a patient with chronic spontaneous urticaria in your office, okay, and you ask for the triggers, and they said to you that probably the disease started after COVID or after an infection, or maybe they are in the consultation and they say to you they have chronic spontaneous urticaria, autoimmune, but they suffer from fever for an infection and they suffer an exacerbation of the CSU. I think the infections and the medications, especially the non-steroidal anti-inflammatory drugs, can be considered triggers and can be considered also the reason for exacerbations inside the course of a chronic spontaneous urticaria. Then what's, Hermenio, your recommendation for one patient? Do you explain to them, or do you avoid the use of non-steroidal anti-inflammatory drug, or according with the history you moved? What do you do?
That's a very interesting point, Anna, that you brought, because we know that one of the process of activation of the mast cell is through the block of the cyclooxygenase pathway. So basically, we can liberate leukotrienes that can activate these mast cells. So if the patient comes to me and there is a clear association, I ask the patient to reduce the use of this anti-inflammatory. And sometimes that could be a point that help with anti-leukotriene medication could be helpful in that kind of cases. But in general, I have to have a clear kind of component of this amplification, let's call this way, of the anti-inflammatory kind of pathway. I don't know if anyone wants to jump in and add more.
Yeah, I think just for the patients to make clear. So there's two kinds of molecules, at least, that can trigger the mast cell to release the histamine. Now, and one of the molecules is leukotrienes, which Hermenio is speaking about, and these become more in my body when I take aspirins and related medication. So I normally, when I have an acute urticaria patient, I do tell him, try to avoid, at least for now, and when you have a headache, you better take acetaminophen or paracetamol, and when you have muscle aches, you'd better take an inhibitor of COX-2, and I give 1 or 2 that are here available in Mexico. So because this is probably a trigger, and I also make clear this is not the cause of your urticaria, but again, it can trigger out your urticaria and make it worse. So we'd better try to avoid. Same thing with some foods. No, the big vast majority, it's not a cause, but it's a trigger. So you'd better don't eat too much of those things that can again liberate more histamine in your body, because it makes your urticaria worse.
But Desi, you and me and Hermenio and Tayseer, we are experienced and a little bit old. I don't know if you had the experience that someone, for example, for cold urticaria that started after an infection, tried to treat cold urticaria with antibiotics.
No.
Yeah, no. Okay, okay. It has been done. I don't know if there are many patients that probably were, maybe someone in the audience had this experience, no? As with psoriasis, it was.
Yeah, that's absolutely no go. Completely agree, Anna. Yeah.
And Hermenio, I see that you have answered a very important question that we did not address actually beforehand, and I would like you to just vocalize it for everyone who may have skipped it or missed it. So there is a question that that regards the transition from acute urticaria to chronic urticaria and the biomarkers that can facilitate in predicting whether the patient can transit from acute urticaria patient to chronic urticaria patient or not. So could you please elaborate a little bit on that, more on that?
Thank you. Yeah, it's kind of we do not have a good number because that's a very difficult study to be done, and I know that Charité has done studies in Japan, has come with studies about this transition. It's very difficult to get these patients because usually they don't come to us; they come to the emergence. But basically, the numbers varies from place to 9 to 25% of these patients can evolve. And some of the predictors that we can find is that when we got in contact with these patients, if the patient has a high UAS7, could be a predictor of severity of the disease, or that's going to evolve to chronic spontaneous urticaria. In the presence of antithyroid peroxidase, the anti-TPO, antibodies that can predict that that has been associated with thyroid disease. That is another predictor that can increase the chances that you are going to evolve to chronic spontaneous urticaria. Other than that, we still trying to find biologic markers that can help us to predict this kind of evolution.
Yeah,
thank you so much.
One word here, just sorry. I think sure, I very much agree with Hermenio. There's very little data on it because we normally stress very strongly, don't take laboratory things when an acute urticaria patient comes in, because normally it's really acute and it's just going to go away by itself. And only if he comes back after 6 weeks and the hives are still there, then I always tell my patient, I will start thinking. Then we do the lab testing, but normally we don't do it, so we don't know those who came in with which or what thing will go on to chronic. And I also think this is more like an academic question than a real important question to the patient. If it's going to be a chronic, it's going to be. So anyways, no, we're not going to change the natural course of that.
That's true. And we are now jumping into a different section that regards urticaria and the body in general. So Tayseer, I would gladly move to this very relevant and now also from the audience very frequently asked question about the urticaria and the implication of getting pregnant, having IVF, or can urticaria be related with miscarriages? Are there any data on this?
I believe that urticaria cannot affect the fertility of patients.
and it has no effect on the pregnancy progression, if it is, and no effect on IVF. If anyone want to add more on this?
I see this question came from the patient because it's really very important.
It is very important
It's really very important, and sometimes I had the experience of a patients that really got different difficulties to have a pregnancy to the end. Yeah. It's really is not studied. One thing is if it's impacted in the fertility, which is not the case. I don't know, Hermenio and Désirée, in the fertility, no. But the other thing is in the progression of the pregnancy, there is no study on this. And sometimes we have the experience of certain ladies who had different type of, maybe they're related with an autoimmune disease. Then when you have abortions, repeated abortions, you should study why it happens. And maybe it's an antiphospholipid syndrome and as another autoimmune disease, no? And the other thing is what it has been published by the UCARE, completely different. If you suffer urticaria, what happens is if you get pregnant, Désirée and Hermenio, what happened? And they say sometimes the urticaria disappear during pregnancy completely, and other times no. Then what do we do in this sense?
Completely erratic courses, you know, it's unpredictable almost. But I think the important part here is that you can continue treatment during your pregnancy. Now, please don't, because here the gynecologist said, no medication at all. And then the poor patient comes in, but miserable, which is completely off. No, antihistamines, and particularly the newer antihistamines, are completely safe in pregnancy. We've been using them now for decades, and we know there's no problem. Not the old ones, but the ones that we normally use for urticaria, and even omalizumab and Xolair. You can just continue. It's classification B in the United States, which means you can use it during pregnancy under supervision of your physician, surely.
And Hermenio has actually discussed it already in the chat with the audience. So Hermenio, continuing on this note and on the treatment during this difficult time, is there also known that the birth control or hormones or menstrual cycle may affect urticaria and vice versa? Are there any such knowledge available already?
Well, that's a very interesting question. I mean, like, do we have everything set in stone in urticaria? No, we know that. But for sure, we have patients that come to us and explain that part of the process of activation of or they get more intense activity of the disease, sometimes even with manifestations that sometimes they do not have angioedema, and during the menstrual cycle, they have angioedema. We have seen these cases. And other patients have report that as well, when they enter with the use of birth control, they develop more activity of the disease as well. So for sure, there is kind of components. One of the processes that I always call attention to the patients, the menstrual cycle is an inflammatory process. So we have to call attention that we are dealing with an inflammatory disease. When you have the menstrual cycle, you activate inflammation. And as a result of that, as we all have seen this throughout this today, we have said multiple times, inflammation is a trigger of worsening of the disease.
Yeah. And Désirée, we have already touched a little bit upon this, but could you please elaborate a little bit on that, whether there are known some increased risks of getting oncological process activated when having urticaria?
Yeah. Here we have three different points here. One, if urticaria can be a manifestation of an underlying disease, one of them being malignancy, cancers. This is super rare, but it is true. And I think it is there's also so important for a physician to really take a good history If I got a chronic urticaria patient coming in here for three years with symptoms, I'm already no problem, because it's not malignancy. No, because 3 years malignancy would already have been too developed. But at the start of urticaria, when it becomes chronic and is really difficult to control, you always have to bear this in mind, and that's why we take certain lab testing. We don't take a lot of lab testing, we should not, but we take certain lab testing because the most frequent malignancies linked to urticaria, like causing the urticaria, is leukemia and lymphomas, and maybe thyroid cancer. So really, this is again important for your physician to be keen on, but it's super very rare. I published on it and we searched all literature the last 20 years, and I think there were like 25 cases. So it's really rare. So don't be afraid. There's a very important message. Then second is, if I'm having urticaria, having chronic urticaria, this makes me more, how do you say it, more sensitive to develop a malignancy. This is, I think here we can say no. The fact that your immune system is a little bit strange acting and makes your hives, it doesn't make it also more sensitive to one day making a malignancy. So there you can be you're on the safe side. Then the third part is, if the medication we give could heighten your risk to develop malignancy. Here, I do think it is important to speak up, because if you Google it, there still come the old things from the last millennium. Come on, guys, this is last millennium where we thought that omalizumab was linked to malignancy. And there's still people keeping repeating this. Well, we're now 25 years more ahead. We've been looking very keenly to omalizumab, to updosing omalizumab. And I also form part of the International Severe Asthma Registry. So we have also asthma patients being treated for over 20 years now with omalizumab. There is no signal. There is no signal anymore, although at the very start, we were a bit afraid that it might. I think now we can really give the answer, no, there's no problem with omalizumab, and yes, no developing malignancies.
OMA can be shared with any chemotherapy that we use for other malignancies. The only comment that I wanted to add to the extremely well-developed answer to the question done by Désirée is that sometimes there are certain procedures in the cutaneous, in the skin, which seems to be urticaria and there is not. For example, the initial stage of a bullous pemphigoid. There are patients even treated with omalizumab with bullous pemphigoid. We had a case treated within 5 years, and it was a bullous pemphigoid, and this bullous disease can be concomitant with cancer. And if it's pruritus, just pruritus with no hives, always you should look for cancer, a lymphoma, or a hematological procedure with this below. But chronic spontaneous urticaria by itself, the true one, there is just one study done in Taiwan based in a population registered where the data, the inclusion of the criteria where is not, we cannot believe on this. That means, but take care, because there are other differential diagnoses with chronic spontaneous urticaria that should be addressed by the specialist.
Exactly, and we have also had request to elaborate a little bit briefly on one patient case that is currently under the treatment with breast cancer, is after mastectomy and currently on tamoxifen, and she is having urticaria, and her main concern is that the cancer may reoccur after the omalizumab treatment. So I think we have noted on this, we have highlighted it, but just to make it very, very clear, what is your opinion on this?
Yeah,
everyone?
We are dealing with clinical trials, and sometimes it circumstantial happens, and we do not consider it's related with the drug.
Amazing. Good. So we have discussed a little bit about the parasites, infections, and so on. And Anna, maybe you have some newest knowledge on one of the most known and hottest topics in the research, microbiota and dysbiosis of the skin and gut. Is there a relation of dysbiosis and urticaria?
I don't know.
This is something we have to still
I don't know. I don't know.
There's
In
always
fact,
a link.
yeah, I don't know. Really, sometimes you have, look, this is very interesting. We did a study in the microbiota in population Caucasian, and there is some changes compared to the control patients. And all, but this work who was conducted by Indra Hispoder, but in our department, and also there is another one from China, and there is a different microbiota in the CSU patient. But if it's related with the disease, the severity, and if we can manage with the dysbiosis in order to improve the disease, we are far from here. The only thing that I can say from the practical point of view is that sometimes some patients prepare the intestinal, all the intestinal, for doing a colonoscopy, for example, or an endoscopy. And during this period that they do this cleanage of the digestive apparatus, they feel better. They feel better. The hives does not appear, but after they reappear. Then I will not nowadays recommend any treatment for because we don't have evidence for this. Regarding parasites and infection, this is different, because the mast cell is involved in innate immunity, and it can be considered a trigger, but not. No.
Yeah.
I have.
Would you like to add something?
Hermenio, or maybe in Doha in.
Yeah, I will say the same. I mean, like we do not investigate this. We have, if by any chance I'm investigating a patient and have epidemiology for some parasitic disease, we need to have epidemiology, which is not common in Canada, and with eosinophilia, something like that. So we are considered. So I'm interested to know what Tayseer is gonna say, like she's in Doha. So maybe if there is any different approach.
Actually, I don't have a comment on that. I'm not sure if it's a better.
Okay, so then we have had quite a few questions from the audience regarding the nervous system, the stress experienced in the early childhood, the nervous system relationship with the flare-ups, with the occurrence in general of chronic urticaria. So, Hermenio, could you please tell us what is known at the moment regarding the nervous system and stress, especially, and the chronic spontaneous urticaria?
Again, we are talking about inflammatory disease. Any inflammatory disease under stressful situation, we activate the immune system. We know that the immune system responds to adrenaline as well. We have a lot of receptors, not only on the mast cells, but also on the T cells that can activate this system. So we have to recall, if the patient has a clear characteristic of stress-related kind of urticaria, in the baseline, there is a urticaria there. It's just as we are highlighting here, like Désirée gave a good example of a patient that of patients that, like in seasonal allergies, they develop hives because they have a certain level of activity of the disease that the inflammation kind of make you superficialize that kind of component. And after the season gone, that kind of process goes back. We see this all the time with triggers, but for sure, this is a typical example of neuroimmune endocrine kind of a situation. And we have to call attention that the nerves are very close to the mast cells, and it can participate on that kind of process.
And it's not contradictory with the autoimmune hypothesis in CSU. It's not. because when we studied the cause, the trigger for this percentage of people who really suffer along their life more than episodes of chronic spontaneous urticaria, we did a multivariate analysis, and the common trigger was severe stress. Stress means suffer from things, not just suffer from working and going and running. No, suffer life suffering for things that really touch you. Then in prone people to develop urticaria, because they are prone to do this type of inflammatory response.
I completely agree. I think it's a very important part. I always call it an emotional stress. No stress that really hits your heart. Not I'm like crazy working up and down. No. But the thing that really hits you like in your soul. That is such an important trigger. And if we come back to the mast cell again, the mast cell has also receptors for neuropeptide and for substance P, which are substances that are produced when I'm under this emotional stress. So there's really this link with the emotional part of my being.
So this is once again the message we send, that taking care of yourself holistically also on your mental health is very, very important in terms of urticaria too. And with an aching heart, I have to thank you so much, because we are 1 hour already in our webinar, and unfortunately we have to slowly come to an end. I thank sincerely all the participants. It's been an absolute blast today. I hope the audience has enjoyed it as much as I did. It was amazing. It was a new concept. I hope you liked it. But if you have missed anything at all that we've discussed today, or you would like to request some new topics, new webinars, please be sure to stay connected with us on the social media platforms. Scan this, and we will definitely post short videos of today with the most important information. And be sure to register for a next appointment that UCARE has prepared for you. This is definitely going to be extremely interesting. It's going to be all about the children and chronic spontaneous urticaria. I'm also joining in definitely to see and learn something from amazing experts giving us the presentations. I invite you to. And today we took a little bit of a risk. We tried to juggle with multiple questions, and we are very much excited to hear your feedback. How did you find this webinar, and would you like to see something more? We have a huge list of questions that we still did not manage to answer, and we would be very, very happy to do so.
We're not even halfway, Aiste.
Oh, yes, I'm super sorry.
Congratulations, Aiste.
Excellent.
Hermenio, would you like to say a few final remarks? No, Hermenio, you have your head.
Sorry.
No?
There was a mistake. I was trying to put
exactly. I was also looking at you.
So please applaud yourself, applaud the audience. Thank you so much, everyone. And I wish you a lovely evening, and I hope to see you next time very soon.
Thank you.
Bye.
Thank you.
Thank you.
Wonderful.
Thank you.